Thank you, Jerry, and thank you for the invite and the opportunity to be here. A relatively obvious disclaimer, I am a shareholder of Gray. So as mentioned, I'm going to be talking about implementing advanced algorithms both on the AI side and the operations research side to optimize something that isn't necessarily very sexy, but core to patients, providers, and really healthcare as a whole in scheduling. So very briefly, as far as kind of how did I get here, what ended up leading me along this path. Started in physics. All of this was done at McGill, moved into medical physics in both the master's and the PhD. And through that, started to move into this area of clinical decision support using AI to, as we've heard about a lot today, try and really personalize medicine. To make a very long story short, sort of in the final, let's say 1 to 2 years of that PhD, the scheduling thing started to rear its ugly head and really start to stick out as something that was in dire need of a solution and wasn't really necessarily being given the respect that it deserved by a lot of the existing tools that are out there. I often refer to them as legacy software. So things that we would be hearing, wait times are increasing, scheduling process is inefficient. When one person's gone, they've been here for 20 years, they hold all that knowledge in their head, and everything kind of just falls apart when they're gone. Overworked staff, treatment and trajectories are constantly getting more and more complex. And I know we have the data somewhere, but I'm operating in the dark. Effectively, we know the EHR or the OIS holds all the information, but it's not actionable in any way. So with all of this, kind of to summarize that, it's a very siloed environment. Patient volumes are only increasing. It's very complex. There's a lot of ambiguity often. You can kind of think of the scheduling challenge as this 18-dimensional game of Tetris where every block is changing color and shape, sometimes in an unpredictable fashion. And the sort of the supply-demand challenge isn't always clear. Sometimes a physician or another staff member's schedule isn't necessarily black and white. Maybe there's half an availability that in a pinch could be used. And really trying to manage all of this is not easy. And this can cause a lot of stress, both on the patient, as far as when is your appointment. Personally, I don't think I've ever actually shown up to a medical appointment that was at the time they said it was going to be, except maybe a dentist appointment. They have it pretty well figured out. But other than that, it's not great. So if we can clean that up, it's a benefit for everybody. And then just staff who have to jump through hoops every single day to try and manage just day-to-day operations. So ultimately, we were seeing that the tools and the manual processes that are implemented don't really allow cancer centers to efficiently deliver the best possible care. Aaron earlier spoke about the amount of money that is spent on healthcare. Not to be pessimistic, but we're trying to do more with less. If we can do more with what we have, we don't necessarily need to spend more. So really the core issue, these inefficiencies, we really say, look, okay, they affect 3 crucial aspects in a very negative way. The patient experience, the staff well-being, and then financial performance, which broadly speaking really just means the efficiency of these expensive resources, whether that's a physician or a nurse or a linear accelerator or what have you. So with all of this in mind, and I'll kind of get to the partners that we made along the way and really made this happen, the idea slowly crystallized really over the past 4 years into what we now call Gray OS. We kind of look at this as an operating system for oncology, really to automate, optimize, and orchestrate all of the logistics of a cancer care trajectory. So how this works, first off, we lay a foundation. The idea here is to really leverage and integrate the existing environment. We're not trying to be an EHR. We're not trying to replace that. They do a lot of stuff. Part of the point is we want to help with pieces of that puzzle that they don't necessarily address. So we work with what is there, but then provide one environment that can really coordinate all of the different pieces of the puzzle through multidisciplinary care trajectory templates, really trying to break down the silos across these different pieces, automating the entire process, as I mentioned earlier. And then, of course, we want to make sure that every piece of data that enters this environment and every piece of data that ultimately resides within the hospital network is actionable to the benefit of both the patient and the provider through kind of your usual analytics and dashboard suites. So to highlight this, right now, it's one software, but realistically, we do look at this as having multiple connected modules. And I would say the main pillars being two of the main, with surgery, of course, being a missing piece here. 2 of the main treatment modalities being radiation therapy and infusion therapy. And then these are all connected through the software and through the patient, along with what sometimes I refer to as appendages of those treatment modalities in the consultations, all the imaging, the lab work, and the pharmacy. And really being able to book all of these things in one environment, have visibility over all of it, and ultimately just improve efficiency and avoid falling through the cracks and wasted resources. So to actually do this, a key motivation at the start really was, as an academic for a decade or whatever it ended up being, seeing a whole lot of research that unfortunately never actually made it into practice. And that's part of what we really wanted to try and change, to actually take research, which in the case of the operations research algorithms have been written about. I'll show you a couple of the founding advisors who have been responsible for it. It's existed since the 90s. A lot of it is used in the airline industry, and a lot of it hasn't made the step into healthcare, even though there's a lot of value in doing so. So we really wanted to try to change that. I can't say enough good things about all of our different partners over the years. The SHIM was the very first. The Jewish was shortly after, as far as co-developing this. So we didn't build this kind of in our basement in a vacuum. We were really able to build it with the clinical providers and with the different stakeholders involved, including patients. And that was key to, as I'll show you on the next slide, sort of the co-development process, as we call it. So to give, again, a very, very high-level timeline, we were able to kind of begin co-developing the software, get an MVP in use, start to prove that, hey, this could really make a difference, and then start to turn that into what Gray is today. So the co-development process is very, very simple. And I'm putting this up here kind of just to stress that I would encourage, I know we've heard a couple times about the importance of just collaboration across the entire ecosystem. And certainly I'm biased, but the center of that is industry, patients, and hospitals. And in really 2 or 2.5 steps, first off, just making sure everybody's aligned on what's the objectives, what are we trying to achieve, and then constant iterative feedback loops. No one's going to get it right the first time. There's always a lot of little nuance that isn't picked up on immediately, but being able to test and measure that and then kind of flow that back in an agile fashion, which certainly is a benefit of a startup. It can be harder for bigger companies necessarily to do that, but in an agile fashion, flow that information back into the software and then test again. To give a high-level overview of the impact of what this software has managed to achieve, now we've managed over 1 million appointments. That amounts to tens of thousands of individual patients, reducing wait times on the order of about 17%. In specific, the Ottawa Hospital is one that has spoken at length about this as far as the best wait times that they've ever seen in the province of Ontario. Managing to treat somewhere between 10 and 15% more patients without actually having to increase the amount of resources expended to treat those patients, and then saving a significant amount of administrative burden on the entire scheduling process, and being able to fold that time back into either directly caring for the patient, speaking with the patient, accommodating their preferences, so on and so forth. Where I will conclude is just kind of highlighting another critical aspect that we've really learned over the past few years of having people around the table in the collaboration, again, whether it's on the industry side or the hospital side, that have felt the pain before and have kind of been there in those shoes. So granted, Mark and I haven't actually worked in the clinic, but coming from a medical physics background, Raphael, who heads our operations, comes from a pharmacy background. Elizabeth comes from a biotech background. And then our founding advisors have been sort of working in these different spaces for decades. Really has been just instrumental in credibility and the ability to trust each other. And it's very, very easy. And we have actually fallen astray of that occasionally, where you can lose credibility very quickly if the clinical people on the other side of the table get the impression that you don't really know what you're talking about. And that ultimately that just halts progress. So this has been crucial. And I would encourage everybody who is pushing collaborations like this forward to look at it in a similar light. So with that, I think I can give back a little bit of time, and happy to chat afterwards.